Go ahead.
Welcome to Unremarkable Labs. We have a very interesting presentation today, and I'll let our presenter and our director of all things Unremarkable introduce themselves. Alejandra, introduce yourself, please.
Sounds good. Hi, I'm Alejandra Osario. I'm one of the second-year internal medicine residents at UAB.
Natasha.
Hi, I'm Natasha. I am one of the PGY3s at UAB.
And I'm Bob Centor, and I'm a PGY. Let me count. PGY 48. That's
Very
actually
nice.
true. That's actually true. It's been 48 years since I graduated from medical school. So
That's impressive.
Why don't you tell us your story, Alejandra?
Yes, I will start. I have a 33-year-old female presenting with abdominal pain.
Okay, so with abdominal pain, we always need to know more about the abdominal pain. And since this Unremarkable is Unremarkable Labs, we'll get the story and then we'll get excited about the labs afterwards.
Sounds good. So for our female, she says that started in the right upper quadrant pain. It's been constant, described as like a dull pain, and does radiate to bilateral flanks. She rates it at a 3 out of 10 in severity, and it's been going on for about a month now.
So as soon as you say right upper quadrant, I start thinking of liver and gallbladder, but it's not real bad. But why is it radiating to the bilateral flanks? That doesn't make sense. So I'm really confused by the pain story. Maybe when we finally examine her, has she had any B symptoms? Does she have any urinary symptoms, any GI symptoms, any icterus, any of those things that are going to help us?
So she does say that in association with this abdominal pain, she has had nausea and vomiting. It started off maybe occurring like once a week, but in the last, 3 to 4 days now, she noticed it's become a multiple times a day sort of thing, to the point that yesterday she noticed some scant hematemesis in the emesis. She denies any dysuria, denies any diarrhea, denies any fevers, chills, weight loss, night sweats.
So the vomiting multiple times a day is for how long?
She says it started off maybe like a couple days after the abdominal pain, but has increased its in frequency. So now it's like in the last week happening every single day, before multiple times a day versus before it was happening maybe like once a week.
And what does the vomitus usually look like?
Usually it's just bland, either what she ate or maybe like some scant like bile, but nothing like bright green, and no blood until like yesterday that she noted some scant blood in it.
I find it hard to believe that someone who's vomiting that much hasn't lost weight.
She says she hasn't. She says she hasn't really noticed any weight loss.
I know she says she hasn't, but I'm always skeptical if someone's really doing that. It'll be really interesting when we look at her labs to see whether or not she's maintained nutrition, and we'll roughly estimate that by looking at her urea nitrogen and by looking at her albumin. Although we won't really know if she was a VA patient and had previously been to clinic. I could look up her weight real quickly and look it up, but too often in at most hospitals, there's no association between the primary care physicians or the subspecialists and the hospital record, and trying to put those together is one of the flaws in our system. So we'll assume she hasn't lost weight and not know. So why would she have this relentless vomiting? It certainly could be a way for gallbladder disease to show up. Could it have something to do with the pancreas, perhaps? Sometimes you can get this. Usually the pain's a lot more severe with either one of those. Have to worry about a variety of liver things, so we'll probably get some liver numbers later on, I suspect. So is she being admitted to the hospital, or is she an outpatient right now?
She's being admitted to the hospital. Yep. She presented to the ED with these symptoms.
Right. So right now, I don't until we examine her or get labs, I don't see a reason for admission. So continue us on the journey.
All right. In addition to the only other like kind of review of systems that's pertinent and positive in her case, she has noted that she is just very fatigued over this month as well, along with this abdominal pain, and has been noticing progressive dyspnea on exertion.
Yeah, I mean, so the question when you have progressive dyspnea on exertion is it the heart? And the heart just showed up all of a sudden. Although sometimes heart pain can be upper quadrant pain, especially if it's inferior myocardium. Is it the lungs or is it the blood? All of those will give you dyspnea and exertion. Now, neuromuscular disease, a variety of other things. So I'm really glad that Natasha put renal up there, because could this be chronic kidney disease, stage 4, stage 5 chronic kidney disease? Now, why would she have bilateral flank pain? Maybe she has stones. And while we always think of stones being very severe pain, I've seen patients with bilateral stones with obstruction who didn't complain of pain. So even though most people have horrible pain, not every patient is most people. So our differential is really, really broad right now from this history. This history to me does not narrow it down at all. I'm going to have to examine her and get more labs. What do we know about her? Does she have any past medical history? Oh, and what's her menstrual history?
Yeah, so I can start with medical history. No, nothing significant. She has some seasonal allergies. She's on Claritin daily for that. Otherwise, it's also on like an OCP for contraception. In terms of menstruation history, she had menarche around age 12. Her periods are regular. They occur every about approximately 30 to 31 days. And she says they're pretty unremarkable, last about, 5 to 7 days, denies excessive bleeding or spotting in between periods, denies any like clots or like bleeding through clothes or anything like that.
And she's not pregnant.
So she says no, that she's not pregnant. She is married and is sexually active with her husband, but says that she's adherent to her OCP. Last menstrual period was 1 week ago, so doesn't think she could be pregnant.
And we'll still get a pregnancy test, because if a 33-year-old woman comes in with any symptoms and you don't get a pregnancy test, sooner or later you're going to make a mistake. Mm-hmm. Okay. With most of my VA patients, I don't need a family history, but with her, I do need a family history because she's rather young. So is there any significant family history?
She had an uncle, a paternal uncle, who had maybe some sort of a lower extremity DVT. And then she had her grandfather had colon cancer, but into late presentation, I think she said he was diagnosed like in his 60s or 70s. But that's it in terms of family history. No surgeries. And then social wise, she has like a desk job, denies illicit smoking, over, like I mentioned, sexually active just with her husband, and she has like a 2 to 3 year old child who's in daycare.
Is just one pregnancy?
Correct, just one pregnancy.
Okay, well, let's examine her and try to figure out why she came in the hospital.
So really, her exam was very unremarkable. Her labs were pretty stable, other than maybe some marginal like high blood pressure. She did say that she hadn't been in like in the system, like primary care, in a while. And then she's a little overweight as well, BMI of 21. And really, exam is unremarkable for the degree of abdominal pain. On my exam, she was soft, non-tender. She did not have any rebound, negative Murphy sign. The ED did perform both a pelvic and a rectal exam. Those were unremarkable per the ED. And really the only thing that maybe questionable was maybe a little bit, her conjunctiva seemed a little more pale than usual. But physical exam was pretty unremarkable.
Yeah, technically heart rate of 100 is tachycardia, but 90 is pretty high.
Yeah, borderline.
And
Yeah.
90 gets my attention. Why would she have a pulse that high? Her BMI is 27. That's not real bad. That's almost slim in Alabama. Pale conjunctiva, usually when that shows up on the exam, somebody knows something about what the hemoglobin is. And certainly anemia would explain a lot of things, but then the question is, if she has anemia, why does she have anemia? So I'm going to bet she's anemic, and I bet that's why she got admitted.
Yeah, and you are correct, Dr. Centor.
Wow.
Her labs, her basic chemistry was unremarkable, but she was notably pancytopenic on CBC.
Yeah, so let's look at this carefully. Let me just look. Everybody who knows me knows I have to look at the basic metabolic panel. Her urea nitrogen is 7, which means she actually is getting protein down, and so maybe she really didn't lose any weight. Her creatinine is 0.5. That's, I think that for a 33-year-old woman, that's really pretty good. She doesn't have the metabolic alkalosis you might expect from profound vomiting, so it sounds like she's digesting some before she vomits. Now we have a pancytopenia. Now the question that you always have to ask when you have a white count of 3.7 is, do we have any old white counts? And the reason is, and this is the one time that I want to know whether or not she has any African ancestry or Middle Eastern ancestry, because there's an entity called benign ethnic neutropenia, which might not be the best name, or benign neutropenia, and it's related to a gene, and if you have it, you run a lower white count. It was found predominantly in southern African states, and the reason that it is fairly common in that area of the world is because it protects you from malaria. And so before I say 3.7 is neutropenia, I want to know whether she's had it before. Is this lower than she's had it before? If she's of Scandinavian origin, then I don't have to worry about that. The hemoglobin 6.5 certainly is very low, and the platelets are very low. Now, what would cause pancytopenia? I think that's the question, is why do you get pancytopenia? So we have to think of, could it be a myelophystic process? And I just love that word, myelophystic, which means something else is invading the bone marrow. So it could be a leukemia of some kind. It could be a tumor that's metastasized there. It could be something that's not a liquid tumor, but a solid tumor, or it could be B12 deficiency. B12 causes pancytopenia, and we always have to think about that as a possibility. And then we'd have to figure out, why does she have B12 deficiency? I'm glad that we had adrenal insufficiency up there. I find that less likely with that good of blood pressure. We didn't really get a story of problems with salt. Her sodium and potassium are both pretty good. So, potassium is down just a smidgen, but she's vomiting, so I'm not too excited about that. So how are we going to work this up? Well, according to my great colleague Jory May, who's our great benign hematologist, she'd say, well, you always start with the retic count and figure out, is it a production problem or is it a loss problem? I think it's more likely to be a production problem because it's pancytopenia, but I think we'll start out with that and see if we can get someone to look at a peripheral smear who is good at looking at a peripheral smear. And I think we need to make that the center of what we're doing. Perhaps we might have an MCV that might give us a clue. We might have a RDW that might give us a clue, but really the clues are going to be from the reticulocyte count and from the peripheral smear.
And I have both of those. So in terms of the peripheral smear, we did hematology was consulted, and they did notice occasional schistocytes with macrocytosis of the red blood cells and hyperpigmentation of the red blood cells, as well as hypersegmented nuclei of the PMNs. And then in terms of the retic count, it was 1.6, which was hypoproliferative.
Right. So the multinucleated polys are what we always jump at. And we hope this is B12 deficiency because we know what to do about B12 deficiency. It's really easy to treat. So her bilirubin is a little bit up and it's indirect, which suggests hemolysis, right? And her haptoglobin is low, which suggests hemolysis. Her LDH is really high. And you do get hemolysis with B12, and it's in the bone marrow often. So I think we have to get a B12 level. Now, what do we do if the B12 level is not technically abnormal? I've actually been reading a lot about this recently, and was actually at a conference where a pathologist explained that the normals for B12, which is technically below 180, that normal is not really a good normal. And then the articles that I've read recently says that any B12 level below 400, you can assume, and you have the right clinical picture, you can assume B12, and MMA is the right to do it, is the right test. It's the best test, much better than homocysteine. So what I would do in this lady, because of the multinucleated polys and the LDH, I would get a B12 and an MMA and go on from there. I do a careful neurological exam. A lot of these people have neurological problems, although she says she doesn't. I think we can explain her problems with dysmenorrheic exertion just on her hemoglobin. When you get down to 6.5, you're going to have dysmenorrheic exertion. Still don't understand the right upper quadrant pain, and I don't understand the flank pain. And I wonder if giving B12 will help. Now, why would she have B12 deficiency? So I'm going to bet she has B12 deficiency, but now I got to ask why. Well, classic pernicious anemia. So she could have pernicious anemia, and then there are tests we can do to document that it's pernicious anemia. There, many years ago, when I was a PGY 1, 2, and 3, we used to do the Schilling's test. And the Schilling's test had a bunch of parts. The first part was if you add intrinsic factor, does it get better? But there are other things that can cause it. So we don't have a travel history or anything, but fish tapeworms can do this. A variety of malabsorptive disorders, celiac disease could do this. And so the question will be, is there a GI cause of this, or is it straightforward pernicious anemia? She has not had abdominal surgery. We used to see a lot of B12 when people were doing Billroth 2s. Billroth 2 is an antrectomy and a gastrojejunectomy. If you take out the antrum, you get rid of intrinsic factor. And so sooner or later, you're going to need B12. And that was the most common operation in the US in 1975 when I was an intern, because it was the ulcer operation. This is before PPIs, before H2 blockers. and before somebody decided that it was a bacteria that caused the infection. So it was a very common operation, and we knew all the problems with that. Those people also got iron deficiency because if you don't have acid, you can't absorb the iron that you eat. So people who become achlorhydric need to be supplemented with iron in some way. So I think that what we have to do is, let's hope it's this. Now, might they do a bone marrow? I think if we get the B12 and if we get the B12 level back fast enough, or the MMA fast enough, that we can avoid doing a bone marrow. But why don't you teach us something, Alejandra?
Yeah. So we went ahead, B12 was obtained, and luckily did not have to do bone marrow because the B12 level was less than 50. We also, for good measure, also obtained a homocysteine and methylmalonic acid level, which were both significantly elevated. So we were able to forego bone marrow biopsy, but it turns out patient did have significant B12 deficiency, like you said, Dr. Centor. We ended up also just to kind of complete the workup, got other nutritional labs in terms of like iron and folate, and those were fine. And then she'd also, in the emergency department, had a CT abdomen pelvis with contrast that was completely unremarkable, and then a normal ultrasound of the abdomen. So it turns out this patient had significant B12 deficiency, and based on hematology's recommendations, they did recommend workup consultation with GI for the common causes, like you mentioned, pernicious anemia and or celiac disease. GI saw the patient and actually deferred an inpatient scope, but did recommend celiac testing, which was negative for the patient. But instead, so we instead went through the path for pernicious anemia, and then that testing was actually positive. So she did have a positive antibody to intrinsic factor, as well as parietal cell antibodies, consistent with pernicious anemia.
So do you have any follow-up on whether her discomfort and nausea and vomiting improved once you gave her B12?
Yes. So based on those findings of the significant B12 deficiency, and then with the positive pernicious anemia workup, she was started on subcutaneous B12 or IM B12, so parenteral B12 injections, and she had complete resolution of her symptoms while inpatient. And then she followed up with hematology oncology as an outpatient, and still had complete resolution of her abdominal symptoms, and her pancytopenia had actually resolved as well.
So B12 is so fascinating. At the conference that I went to, a statement was made by the pathologist that we probably are underdiagnosing B12 deficiency, because we'll get back a B12 of 320 and we'll say, well, that's normal. Well, it's probably not normal. And so I did find some articles about this that said that reflexing to MMA. And then I actually tweeted about B12 deficiency because of something that someone had discussed, and we were working a patient up at the VA for B12, and some experts think that B12 is because of the normal levels, that we should just automatically go ahead and get an MMA. I did read some articles that said that the homocysteine is just not as valuable as the MMA, and if we just went with the MMA, we'd be much. That's all we really need to do. The other thing you have to know about B12 deficiency is that it can present without hematological problems. And I've seen a couple of patients and have been told that as many as 25% of people who present with neurological complications of B12 deficiency will have totally normal hematology. We classically just think of the nucleated, the multinucleated cells and the anemia with a high MCV, and we don't think about the platelets. We don't think about the pancytopenia. I've seen pancytopenia with B12D4, and it's definitely in the differential. And as I said, that's what we hope she has, because it's a whole lot more fun to treat B12 deficiency than to treat leukemias. To me, the most important lessons here are you go ahead and get a retic count, and then you go ahead and look at a peripheral smear. And those are the two things that too often I see not being done. So this meets my definition of a great case, because you figured out what was wrong with her and you treated her and she's doing well. And it can't be a great case unless the patient's doing well. What else can you teach us about this, Alejandra?
Yeah. I mean, at least for me, this was a case I encountered my intern year. And for me, I did not realize initially that B12 can be a cause of actually hemolysis, both intramedullary as well as extramedullary. And it honestly can be a mimic for like TTP. So initially, when we did get the indirect bilirubin, the elevated LDH and haptoglobin, we were concerned even for something like TTP. But then that was a good learning point for me that B12 can cause hemolysis and is a mimic of TTP. And then I was always aware of, B12 causing like anemia or causing, subacute degeneration, like neurologic symptoms. But B12 deficiency can cause sometimes very vague abdominal like symptoms, like abdominal pain, nausea, vomiting, that kind of picture. So that was just something else I added to my illness script for B12 deficiency, because I was unaware of that when I was an intern when I had this case. So I thought that was a great case for that reason as well.
Natasha, do you want to take us home, and what do you think are the big lessons as a senior resident? If you were going to sit down with medical students and interns tomorrow and teach them about this case, what would be what are your big take-home points?
I think having a broad differential with non-specific complaints is really important. I think Alejandra, great job on this case. I think this diagnosis could have very, very easily been missed. Someone had the foresight to think about B12 deficiency, because like Dr. Centor said, typically we think of neurological symptoms, and the hematological manifestations aren't necessarily as common. And so I think when your illness script is something's not clicking, the important thing is to think outside of the box. And that's when you pull up some articles and think about what else. I figured it was going to be an interesting case, and that's why I thought of adrenal insufficiency early when you said that non-specific abdominal pain, because I've seen a couple of cases of that. And I've actually seen multiple cases of B12 deficiency and never seen it present like this. So I think reminding especially our earlier learners that atypical presentations of common diseases exist, and knowing when to look things up. Because I don't think it's the hemolysis and even the thrombocytopenia and leukopenia. I think people think of less likely. They think of more so the anemia. I guess I just have two quick questions for you though, Alejandra, just for my curiosity. What was her MCV? Was it elevated?
It was, yeah. Her MCV was about 110. So it was elevated.
Okay. Wow, that's very elevated.
Microcytotic anemia. Yep.
And then I know she didn't get scoped, and it doesn't necessarily fit her presentation, but I'm wondering if she could have had some autoimmune gastritis going on causing her belly pain. I don't know.
Well, so I think they diagnosed that she had the parietal cell antibodies.
Oh, right. Okay.
Which is the classic pernicious anemia.
Yes.
So it is an autoimmune process. But But I don't think you can treat it other than just giving them B12. Is
Correct.
that right?
Yeah, you usually don't use any immunosuppression or anything. You just replete the B12. And unfortunately, she did follow up with hematology as an outpatient, but was lost to outpatient GI. So she never ended up getting scoped. And unfortunately, we lost her in the system. But at least for her hematology follow up as an outpatient was doing great, and all her symptoms had resolved on parenteral B12.
So one of the points you made, Natasha, I think is really important for all learners, is that even the basic straightforward diseases like B12 is a straightforward. We know exactly why she had it. We know that it can cause a variety of manifestations. What happens the further you go along, like when I was a resident, would I have gotten this? I doubt it. What's happened is I've seen plenty of B12 and I've learned the variations over the years. And it's our job, and one of the reasons we present these cases, and thank you for watching this and listening to this, is to open your mind about what the variations are, and that not everybody presents with the classic B12 deficiency. Some of them have neurological symptoms, some of them don't. Some of them have hematological symptoms, some of them don't. Some just have anemia, some just have multinucleated polys, some have hemolysis. Most of them have hemolysis within the bone marrow, but some also have hemolysis outside the bone marrow. And it's knowing that broad definition of basic diseases that you need in order to keep something on your differential and not discard it because it's not so-called classic. Thanks everybody for watching.